What an honor and a delight it is to be here and have an hour with you to talk about my research. Let me start first with a sincere thanks to the Karolinska Institutet, the Gunnar Höglund and Anna-Stina Malmberg Foundation, and the prize committee for their very hard work. I am so honored by this recognition. And I know that when I look back on my career, many years hence, I've got 20 more years to go, that I will see this as one of the high points, one of the real high points. So thank you. The task I was given was to describe the career of research that's led to the award. I could show you the email. I got the email and thought, my goodness, such a task in 45 minutes. So how do you do that? Well, you write a play, of course. So today, I'm going to present you a drama in 5 acts. The first act, we meet language. Everything I do has to do with language. As Brian said, I'm a rhetorician. That's the study of the social uses of language and words. Many years ago, when I was first invited back to speak to a conference of other humanities scholars and rhetoricians, to tell them about my journey to this strange land called medical education, I created this slide. This is what it felt like to be in medical education 20 years ago as a rhetorician. But I'm not alone on the slide. I never felt alone. It's a very collegial community, and in fact, I think remarkable in its willingness to embrace a wide array of disciplinary lenses and to allow people from different areas to ply their trade and ask questions for the improvement of healthcare and health professions education. But what makes me different, even though I'm not alone, what makes me different is the way I think about language. For most people in the health professions, language is a matter of fact. It's common sense. We just talk that way. I don't know why. Those are just the words we use. That's just the way we do it. For a rhetorician, language is never a matter of fact. It's always a matter of concern. Why do you talk the way you do? What are the consequences of talking that way? Why have you forgotten how you used to talk? Why is it new to talk this way when 50 years ago we did it that way before? One of the fundamental premises of rhetoric is this, that language not only describes our world, language creates our world. The words we choose shape our attitudes, and those attitudes orient us towards some actions rather than others. Language does things. It's not just jargon. It's not just medical vocabulary. It's not just genres like the patient interview, the history interview. It's not just descriptive. That packaging shapes the way we do what we do. It shapes what we think matters. We see language creating the world everywhere. Language creates healthcare. And I'm going to argue that perhaps this is true today more than ever. Let me tell you why I say that. This is Gary. Gary's in his late 80s. He lives alone, has for a few years since his wife died. If you asked Gary, he would say he's doing very well. He's just slowing down a bit. Gary still drives his truck. He gets his own groceries. He cuts his own grass. He lives in rural Canada, so in the winter he blows his own snow out of his laneway. Gary's doing well. He's a high-functioning Canadian senior. And he had 36 healthcare visits in the previous 12 months. He sees his family physician regularly. He sees the nurse practitioner to get his INR checked because he takes blood thinners. He sees a cardiologist for his atrial fibrillation. Recently, he stumbled getting out of his truck, so he sees a physiotherapist. He sees a geriatric psychiatrist for his long-standing anxiety and depression. Increasingly, he's irritated because he sees the dentist quite regularly because his medications are rotting his teeth. Gary is the average. He's not unusual. These are Chi-High statistics from 2011. A quarter of Canadian seniors report having 3 or more chronic conditions. That's about 1 million people. And together they report over 13 million healthcare visits annually. This is the landscape of today's healthcare. And in our more optimistic moments, we use this metaphor. We say healthcare today is a team sport. You've heard this metaphor. But for patients and their families traveling that landscape, healthcare can seem a whole lot more like a maze of disconnected care episodes. And from the perspective of rhetoric, language lies at the crux of this. Whether healthcare is a team sport, a collaborative practice, or whether it's a maze of disconnected episodes, a large part of that we can lie at the feet of language. This is what I've studied for over 20 years. How do teams use language to work together? How do novices, when they're training in those clinical team settings, pick up those habits of language? How do those habits of language shape them as professionals? Shape not just what they say, but what they think, what they value, what they do. And if we wanted to change the consequences of language in healthcare teams, how would we do it? Where would we start? That's what I study. I've studied surgical teams, critical care teams, clinical teaching units like inpatient medicine and pediatric medicine, primary care teams, emergency medicine teams, adult rehab teams, transplantation teams, heart failure teams, palliative medicine teams. I'm agnostic when it comes to the clinical setting. What I care about is what can we learn about the uses of language by studying this team. And as Brian said, I'm a qualitative researcher. I'm a social scientist. So the only way to study how teams talk is to go and listen to them talk. And then ask them, why? Since when? What would you rather do? Which brings us to Act 2 of our drama, wherein I very dangerously proclaim some truths about teams. Now I know there are at least a handful of social scientists in this audience, or those who would identify with that term, Dr. Hodges. And so I might as well admit out loud that social scientists don't put the word truth on a team, on a slide. And if they do, they certainly don't put a capital T in front of it. But I've done that. I'm going to stick my neck out here, because over 20 years of studying teams has shown me that there are some things that hold true about teams. Let's see if you would agree. The first truth is that competent individuals can come together and form an incompetent team. Yes? Oh, lots of nodding. Yes. True. Safe to call it true. The second is that teams can be competent even when one team member is incompetent. This must be true, or no patient would survive an admission to a teaching unit. Medical education is predicated on this being true. The third truth is that an incompetent team member can paralyze one team, while another carries on around her. This fascinates me, and we need much more research into just how this can be true. And the fourth truth is that the same team can be competent one day and incompetent the next. You've all experienced this. No matter what kind of a team you're involved in, clinical or not, you come to work, you look around yourself, and you say, this is going to be a good day. This is a dream team. And within a few hours, the wheels have come off, and you're wondering why it's not. What interests me about these truths is that they're paradoxical in light of how we think about competence. These things shouldn't be true if the way we think about competence is accurate and fulsome. So my argument for the next little bit of the talk is that we actually need to rethink what we mean by this word competence in light of these truths about teamwork. Act 3. The 20th century rhetorician Kenneth Burke said this: every way of seeing is a way of not seeing. This is part of the human condition. We can't take everything in. And so some things we put into the foreground. We attend to them. And other things, often subconsciously, we put into the background. We deflect attention away. Every single piece of language we use does this work for us. It emphasizes something and de-emphasizes another. I would argue that competence is such a way of seeing. It is not a matter-of-fact term to me, even though it is used matter-of-factly and persistently in medical education this decade. How we see competence, in fact, shapes our attitudes and our actions because we're selecting some things to focus on and deflecting other things away. The other thing that Kenneth Burke said, and if you take nothing else from this talk, please accept this gift from me. Kenneth Burke drew our attention to the fact that of course he wasn't the first, but he was very poetic. Some words have more power than others. And Kenneth Burke called these God terms. Words that when you use them, other words and ideas are subordinated. They're not as important. Competence is such a word today in health professions education. Think back. 20 years ago when I entered this field, it wasn't a word that resonated in a room any more than any other word. There were other words back then. But competence is one of the words right now, if you're a medical educator. I like to think of God terms as a kind of rhetorical trump card. So if you sit on an educational committee of any sort, and somebody plays the competence trump card, there's no arguing against that. They've just won. If this is a decision that weighs on competence, they win. We have many God terms around us in our healthcare landscape. If you sit on a hospital quality committee, you will be familiar with the God term patient safety. When that's played on a quality committee, there is no coming back from it. Think about the God terms in your environment, educational and clinical, and the work they're doing, visibly and invisibly. So I'd like us to ask ourselves, given that competence is a word with such power, and given that every way of seeing is a way of not seeing, how do we see competence right now in health professions education? And I would say that we see competence individualistically. If I had to boil this individualist way of seeing competence down to a few key premises, they would be these. That competence is a quality that individuals acquire and possess. This is how we talk about it. Related to that premise is that competence is a state to be achieved. We bring in novices, we fill their empty vessels up with competence. They've achieved the state. And related to that premise, although none of us would ever say this out loud, is that competence therefore is context-free. It's untied to time and space. Now, this is sacrilege. John Norsini told us so. Context specificity is the one truth in medical education. But we behave as though competence is context-free. We don't question when a resident moves from one hospital to another that their competence doesn't go with them. Or their incompetence, if you think about the learner handover debates that are going on right now. This individualist way of seeing competence influences absolutely everything we do in health professions education. We select the best and the brightest individuals. Even when our pedagogy is group learning or team-based learning in its orientation, We still, for the most part, assess the individual's performance out of that environment. Licensing and evaluation is predicated on individual competence. Of course it is, right? We want individually competent practitioners. We want them to be accountable. We don't license teams. We don't pay teams either, which is of course enormously important. And of course, individual competence underpins remediation. Notwithstanding many, many years now of safety science telling us that errors reside in systems, not in individuals, we still, when things go wrong, lean towards finding the individuals responsible, identifying their weaknesses, remediating them, putting them back into the system, and holding our breath, because we know it's more complicated than that. So individual competence is everywhere. What's the problem with that? We want individually competent health practitioners. What's wrong? What's wrong is that research tells us that Gary's individual healthcare visits are likely fine. Where things will go wrong is in the cracks between them. Not likely in those individual interactions with individually competent practitioners. It's the cracks between those individual exchanges that will cause us the most problem in terms of medical error, in terms of patient understanding and satisfaction. So individual competence doesn't equal quality healthcare. That's the problem. It's necessary, absolutely, but it's insufficient in today's healthcare landscape. So a few years ago, in a book that I co-edited with Brian, I articulated the language of collective competence, which I had found first in higher education and then adapted to our discourse and the way we talked about competence. And I argued there that collective competence is a way to see the aspects of competence that aren't reducible to features of the individual, but that instead emerge from social and organizational factors. And if I boiled collective competence down to a few key premises, they would be these. That competence is a constantly evolving set of multiple interconnected behaviors. And that it's achieved through participation and enacted very intimately in certain times and certain spaces. This notion of collective competence I didn't pick out of the air. It has very strong theoretical roots in distributed cognition, with Hutchins' notion that collaborative work is a joint cognitive accomplishment. I love the incongruity of that phrase, because we think of cognitive as what's in here in my head. This idea of a joint cognitive accomplishment is, I think, really important. Collective competence also has roots in situated learning theory, with the notion that competence emerges through social interaction, through learning what's often tacit knowledges and ways of improvising and innovating on the spot. And also collective competence is informed by complex adaptive systems theory, which with its idea that every complex system is inherently unstable. We know this in healthcare. We're always doing innovations in healthcare where we drop something into the pond over here and whoops, something happens over here that we didn't intend. So what I've described here is two ways of seeing competence. Our conventional way, our matter-of-fact, commonsensical way of using the word competence is as an individualist thing, something we possess, something that's stable, something that's context-free. And I'm suggesting there's this other way of seeing competence that brings out of the blind spot some of the things we've put there. A notion of competence as a distributed capacity that's evolving and very much based in situation. I'm not proposing a binary opposition. I'm not saying get rid of individual competence and just worry about collective competence. I'm not even saying collective competence is a solution to all the ails individual competence. Collective competence itself is a way of seeing. It too has blind spots. I'm suggesting that we are best positioned if we have both ways of seeing, and we use them together. So let's quickly revisit some of those truths that seemed so paradoxical. Why is it that competent individuals can form an incompetent team? Because the collective aspect of competence emerges through social interaction. Why is it that teams can be competent even when one member's incompetent? Because collective competence is a distributed capacity. It's not reducible to an individual. Why can an incompetent team member paralyze one team and not another? Because how the system responds to the individual is the key, not the individual herself. And finally, why is it that the dream team is not the dream team every day? Because collective competence is evolving, unstable, and tied to context. And let me give you one quick example. Do you have an electronic health record in your hospital? Were you there when it was implemented? If you were, think back to its effects on your teams. I guarantee you that that change in the context will have changed the collective competence of the team. Because the collective is more than the human beings. It's also the materials and technologies that they use. So I don't know how many faithful theater goers we have here. We have some. In a 5-act play, Act 4 is the crisis. Act 4 is when people feel uncomfortable. It's why it comes after the intermission, so that you can't leave. You're feeling good. You have the intermission. We don't have one today. And then you have Act 4. So you're about to feel uncomfortable. There are a number of myths about teams that are holding us back from treating teams in the way we need to and talking about competence in the way we need to. Let me tell you some of the main ones. Here's the first one. If we just all did our jobs properly, this team would be competent. I can't tell you how many times I have that in a transcript from interviewing team members in clinical settings. If everybody just brought their A game, things would work fine. How about this one? If we just understood each other's roles, then this team would be competent. So this has emerged into one of the fundamental pedagogies of interprofessional education. It's a very important premise. Why have I called it a myth? Stay tuned, let's hear a couple more. This is my favorite. If we just had clear leadership, then this team would be competent. Do you smell the nostalgia in that? For the time when it was clear who was in charge? But this is still alive and well. And finally, if we just all focused on the patient, then this team would be competent. Now this is the point in Act 4 when the oxygen leaves the room. Because patient-centeredness of all of these values that I've pinned as a myth, patient-centeredness is probably the one we hold dearest at the moment. These myths are predicated on things we hold dear. If we just all did our jobs properly, is the value of individual excellence. If we just understood each other's roles, is the value of role clarity underpinning IPE, or much of what IPE tends to get reduced to in our curricula when you have one day or you have a few courses. And any IPE scholar in the room will tell you, this is what we often have time to do. It's important, we wish we could do more. Leadership, patient-centeredness, they're all so important. Why have I called them myths? Let me tell you a story to illustrate why I believe they're myths. First, what is a myth? You can define a myth many ways, but overall, a myth is a story that we tell ourselves to understand something that's complex. It's a simplification by its nature. It's often a story that helps simplify something that's a rather taboo subject and tells us how we ought to behave. It's a lesson. It's a moral lesson, often. So I think these are myths. Let me tell you a story about teamwork to illustrate why. This is a story from our study of transplantation teams. Wilfred Chang is a 56-year-old man with end-stage liver disease. A few weeks ago, he had an admission to the transplant unit for an assessment. And during that admission, he was assessed by members of the transplant team for medicine, surgery, and anesthesia. The whole point was to figure out his suitability as an organ recipient. In addition to his organ failure, Wilfred has a heart stent, which causes anesthesia to be cautious about his appropriateness for listing. The consulting anesthesiologist tells the transplant nurse practitioner that the patient needs a left heart stent before transplant should be considered. Wilfred is discharged home with the goal of building him up nutritionally while the decision is made. But about a week later, Wilfred is admitted to the intensive care unit, and the morning following his admission, he's characterized by the transplant team at rounds as crashing. And they illustrate a very strong sense of urgency about this decision to whether he's going to go on the list or not. But before transplantation, this residual issue from the prior admission still needs to be resolved. Can Wilfred's heart withstand the surgery? Answering this question requires a 5-day and quite delicate negotiation by the transplant team between the conflicting opinions of the services of cardiology and anesthesiology. And here are some of the things that the team members from transplantation told us. A transplant nurse practitioner summed it up this way. There was anesthesia, cardiology, and us. And ourselves, transplant and anesthesia, felt that the patient needed a left-sided heart cath prior to listing for transplant. And cardiology disagreed with that. One of the transplant staff people said this: cardiology was ordering a CAT scan, and it was coronary arteries. And anesthesia said, I don't care what the result is, that isn't good enough, we want a cath. And the cath guy says, well, I'm not doing a cath because you don't need a cath. And anesthesia says, well, we're not doing a transplant then. And we, the transplant team, are stuck in the middle going, guys, figure this out. Do we have anyone here who works in transplant? Oh, we do. One of the transplant surgeons shared this reflection, that sometimes the comment is made by cardiology that anesthesia is being overly cautious. And anesthesia is saying, well, cardiology is not in the OR, and they don't know everything that we have to deal with. The transplant fellow summed the situation up this way, explaining that the compromise between all three services was to order a CT angiogram, which is performed in radiology, thus enter another specialty. But then the radiologist wanted the heart rate to be much better controlled prior to doing a CT coronary angiogram because they felt the false positive rating would be too high. Brian's holding his head with a high heart rate, and so they didn't want to do the scan. Does this sound familiar, Brian? Mm-hmm. Why have I chosen this story? I've chosen it because our knee-jerk reaction is to say, this is abysmal teamwork. But this isn't abysmal teamwork. This is the everyday. This team gets the decision made. In fact, they get it made with good humor and good relations maintained. It takes them 5 days. Wilfred has his transplant. He does well. I've chosen this because our reaction is to say, if this team had X, Y, Z, good, better leadership, better, etc., this wouldn't happen. We need to fix this team. I think this is the everyday complexity of teamwork. That's why I've chosen it. So let me tell you just 3 of the reasons that I think teamwork like this is so complex. The first is that roles are not clearly defined in the practice setting. This is not an unusual situation in that roles are overlapping. Who, for instance, is the heart expert? At least 2 of the specialties can lay legitimate claim in this scenario to that role as regards this decision. That's what makes this complex. The second thing making this complex and everyday is that authority is not straightforward. It is almost always a negotiation. Often, physicians and other health professionals will resort to Well, the most responsible physician should make the decision in the end. Who's the most responsible physician as regards this decision? They will all legitimately feel that responsibility and will behave accordingly as we would want them to. And finally, teamwork is complex because competing motivations exist. Competing, equally legitimate motivations. In transplant, one of the most important is the stewardship of the organ. But another is the safety of the patient. Another is the education of the trainees. One of the reasons this takes as long as it does is that residents and fellows take a try at this negotiation, as they must do if they're ever going to learn to do it. Because of these competing motivations, we cannot simply say, well, let's just focus on the patient's goals. Wilfred wants a transplant, but there are a number of goals that need to be considered and held in play here. I know that the IPE scholars in the room are already advocating in the literature and in their centers for the next generation of interprofessional education, where we take the very good work we've been doing in the preclinical environment, for the most part, in our schools, and move it into the practice setting so that students of various professions can encounter this everyday complexity and see the nuances of that very simple set of knowledge that we provided them in the role clarity seminars that they take. So these myths, if we just all did our jobs properly, if we understood each other's roles, if somebody would just take charge, if we all focused on the patients, they're all good. I'm not saying we should remove these values from what we do. But I'm cautioning that they become oversimplifications when we believe they will fix the everyday complexity of teamwork. And one of the reasons I think we lean towards them, one of the reasons I think I hear them so often in research settings, is that they allow us to slip back into a focus on the individual. They all turn us back to the individual. Which brings us to Act 5, the final act, where I introduce assessment. When I first went to my first international medical education meeting, it happened to be the AAMC RIME meeting. I think it might have been in Boston. I went to as much as I could. I'd started my job in August. The meeting was in October. Excuse me. So I was really new. And I remember saying to a colleague about the middle of the second day, why is everybody talking about assessment? Every session seemed to be about assessment. And to me, assessment was important, but it was one piece of the puzzle. There was this grand puzzle all around it. It was all about assessment. It's taken me 20 years, but I get it now. I understand why everybody's talking about assessment. Because if a new idea, if a new concept like teamwork, like collective competence, does not make it into the practices and languages of assessment, it's not going anywhere. And I have waited 7 long years for collective competence to make its way onto the assessment agenda. And I'm tired of waiting. So Act 5 is assessment. This will be the next 8 or 10 years of my career. So how do we assess competence? Nobody's ever disagreed with me. Of course, I am a rhetorician, so that might be why no one does it in public, but no one's ever said to me, I think collective competence is wrong, I think it's a bad idea, I think it's irrelevant. No, everybody gets on board. They embrace the idea. But how do we assess competence? We look at the individual. Most of us are following some kinds of competency framework, and there's a lot of kind of work underway to shift some of our tools, but for the most part, we're still working with forms like this. This is the CanMEDS rules put onto an ITER, and it causes us to ask assessment questions like, is this emerged trainee a good communicator? Does this emerged trainee demonstrate professionalism? Do you hear all of these things live inside this emerged trainee? And we're looking for opportunities to peel her open and see how much of it she has. We'll tell them no. Please Please wait again. Why is that? Because all of the, I'm going to go so far as to say all, I think it's mostly true. There are a few exceptions emerging. For the most part, these kinds of assessment metrics, this way of conceptualizing what we're doing in assessment in health professions education, it is an individualist way of seeing competence. It orients itself to those things. We don't really have anything yet that can grapple with the idea of competence as collective. So my question is, how do we move? How do we move from an assessment machine, and it is a machine, a very expensive, powerful machine, that focuses on the individual, to one that can actually account, at least in some ways, for the collective of which that individual is a part? The way we're doing things now can't get us there. And one of the reasons they can't get us there is that our underlying metaphor is wrong. This is the metaphor we have for teamwork. It's often tacit. The team is a machine. You'll find the machine metaphor everywhere in healthcare. This idea that there are a bunch of parts and they fit together properly, and then the whole functions well. The reason this is the wrong metaphor is that a machine is a complicated system, and a healthcare team is a complex system. The difference is profound, but fairly simple to describe. The difference is that in a complicated system, the parts are what matters. You make sure they're all working. If it breaks, you look for the part, you pull it out, you fix it, you put it back in. Complicated systems are about the parts. In a complex system, it's the relationships among the parts that matter, more than the parts themselves. So we need a new metaphor. I would challenge you to go away and think about where the machine metaphor, likely never named as such, but this focus on the parts, where that's influencing your clinical and educational practices. We need a new metaphor. And team researchers in a number of domains have started in the last decade to move to biology and ecology for metaphors that might allow us to think about the relationships among the parts. This is a video of murmuration, or the flocking of birds. This is a complex system. 20, 100 of these birds can fall out of the sky. That will not affect the system of flocking. What does affect the flocking is features like geography and wind and a storm. This metaphor frees us up to ask very different questions about teams. Instead of asking, is everyone on this clinical team competent? Does everyone have role clarity? We would ask, what are the features of geography in this clinical unit that would affect this team? Like the electronic health record, like scheduling. We would ask, what constitutes a storm in this environment? Interesting, a student of mine many years ago, Stella Ng, one of her studies of interprofessional and intersectoral teamwork, found that one of the things that was a storm that affected teamwork was Canada's privacy legislation, which completely alters people's ability to simply exchange information as they had conventionally among team members. So you're not looking at parts anymore. You're looking for bigger and intertwined things like privacy legislation. The metaphor is actually quite fantastically freeing, I find. So, with a new metaphor, we may be able to get beyond the parts in assessment to the relationships among them. But to do that, we need new assessment language. So this is one of my most recent publications. It's from this past spring. I worked with a team that was led by a postdoc, Dr. Stephanie Seebach-Sire. And what we did in that team was we said, okay, if independent performance, if individualism is what we're assessing, let's go and ask faculty and trainees this question. In a clinical environment, and here we were looking for clinical measures of performance. In a clinical environment, which trainee actions and decisions are likely to be a reflection of their individual competence? And in a number of interviews with faculty and trainees, of course they told us some examples of independence. But the flavor of the interviews was really a series of exceptions. This could be independent, except that. What we ended up finding was that very few things that trainees do in these clinical environments was perceived by faculty and trainees themselves to be independent. Only rarely did they describe performance as independent. More often, they described it as interdependent, or what we came to call coupled. A few examples. Here's a faculty member from obstetrics and gynecology who says, I don't believe our residents are given true total, I love that, true total independence prior to graduation. You may put the forceps on and deliver the baby, but not without me actually watching. And then the watching is explained as a form of interdependence. Just the being there is a form of interdependence. That challenges some assumptions we've made about if you do it, and you're the only person who does it, then that counts as an independent performance we could assess. Here's a senior resident who says, the busiest night I think I've ever had to work, at 11 p.m. or so, the staff actually called me and said, look, I was just cruising the electronic health record, and I noticed you guys have had a lot of consults. Do you have any questions, or are you worried about anyone? So this is a faculty member who's not even in the hospital. The resident feels completely independent, and they go on to describe their enormous relief at knowing that they weren't, that someone was actually cruising the record from home and knew that they'd been slammed. I'm very interested in these new things called entrustable professional activities. These are supposed to be units that can be performed, that can be isolated and performed and entrusted to trainees. So here's a participant, a faculty member, who, talking about the entrustable professional activity of taking an informed consent, says that it's often the social worker who does that in our environment. So our senior residents, they have to know how to work with the social worker. It's not an independent performance for them, and yet it's an entrustable professional activity that they will be individually assessed on. So what we described in this paper is that actually we need to start thinking about residents working on a spectrum of independence and interdependence. And what we can start to see in our studies now is that in fact specialties have their own texture of interdependence. Degrees and texture. We need to understand this better. But even though we would argue there's a spectrum, the high church of assessment and its orthodoxy is predicated on the assumption of independence. My message is really that we need to stop pretending. We need to stop pretending that the performances we assess are independent, because they won't be. And along with that is actually an even greater challenge, which is to say that rather than seeing everything else as noise, we're trying to get at the signal inside that resident and pull everything else away as noise. If we're wanting to assess collective competence, the noise will be the signal. And we'll need to figure out a language and a set of patterns for interpreting what right now is just noise that we pull out of the assessment machine. So we need new models, we need new indicators, we need new metrics. Really, we need a new language for interdependent performance assessment. So, let me quickly summarize. Every way of seeing is a way of not seeing. And how we see teamwork and competence influences what we believe to be true about them, and therefore what and how we choose to teach and assess in health professions education. Teamwork, competence, assessment, they're all God terms. They're not stable. They've evolved and shifted. And part of that, as far as teamwork and competence is concerned, I consider to be my life's work. To make those words shift, to make them mean something, So when I thought to myself, boy, I'm going to summarize 20 years of research, what have I actually done? That's a moment of real imposter syndrome, I can tell you. Really what I've done is I've played with words. I've tried to introduce some language that wasn't in the field before. That may seem like a light harvest from 20 years of work, but not for me. Because I believe that when we sow new words, we can reap new worlds. In fact, it's the only way that we're going to reap new worlds. Thank you.